everybody. So I'm going to start and I'm going to be followed by Professor Lee, and the title I've been given is Solutions for Implementation of Cancer Survivorship Care. And this is part of the UCC Cancer Seminar Series. And I'm delighted to have been invited to present on this topic area. So we just hopefully, disclosures, I've had some Pfizer funding for research studies and nil else. Just in terms of research, obviously research is a hugely team effort, and I'm delighted to say that we have an amazing team in UCC, in the School of Nursing and Midwifery, and colleagues in the health services, and some of the members of the ECASP team here are listed, and no research would be possible without this broader team, and I want to acknowledge that. So in terms of context, obviously from a cancer perspective, we know that between 1 in 2 and 1 in 3 people get cancer depending on your gender. Approximately 40% of these cancers are preventable. And 2 out of 3 survive cancer longer than 5 years. Obviously, that would depend on the diagnosis and stage of diagnosis. For example, we would have lower survival rates for pancreatic, brain, and liver cancers as an example, and higher for cancer of the testes, prostate, or breast. And we've over 220,000 people alive with cancer in an Irish context. Then in terms of cancer survivorship, this term jars some people in terms of it doesn't really capture the full cancer journey, but it is the term that's used in common policy. Many others use the term living with, through, and beyond cancer. But in terms of the introduction of this term, it started with work of Fitzhugh Mullen, and that was based on a doctor's experience of cancer. And he termed his experience as seasons of survivorship, and this idea that there was acute survival, extended survival, and permanent survival. That was around 1985. And then in 1991, Susan Lee and Catherine Logan were the first to really define cancer survivors as anyone with a history of cancer from the time of its discovery and for the balance of life. Subsequent to that, Institute of Medicine published a really seminal publication in terms of cancer survivorship, From Cancer Patient to Cancer Survivor, Lost in Transition. And within that publication, they really began to draw attention from a policy perspective to the idea that we need to both prevent and control adverse cancer diagnosis and treatment-related outcomes, such as late effects of treatment, second cancers, poor quality of life. And we need to provide a knowledge base regarding optimal follow-up care and surveillance of cancers to optimize health after cancer treatment. So this idea that there was a trajectory and we need to focus on that full cancer journey came into the common dialogue in around 2006. So Patterson in 2023, an Australian group published an umbrella review, and they looked at unmet supportive care needs of people affected by cancer. And they summarized 30 systematic reviews, a total of 666 publications. And they highlighted that we needed to have targeted clinical trials and clinical guidelines and policy around this whole area of unmet supportive care needs. And they highlighted the most common unmet supportive care needs fell in the psychological and emotional domain, the need for health systems, information, interpersonal and intimacy related needs, physical and family and practical needs. So broad range of needs highlighted within that umbrella review. So highlighting that there's some work to be done in this area. Then in 2020, a group of organizations came together in the US, and this is common across the world, where organizations are coming together to recommend guidelines to improve survivorship care. And in the US context, it was the American Cancer Society, American Society of Clinical Oncology, and the National Cancer Institute with the National Cancer Policy Forum. And they published Standard 4.8 on cancer survivorship. And that standard highlights the health system policy requirements and recommendations, the health system processes related recommendations, and the health system evaluation and assessment recommendations. And they recommended that from a policy perspective, that there be a framework for the provision of survivorship care informed by survivor stakeholders and relevant survivorship guidelines, that this be multidisciplinary care enabled framework, and that each team member's specific role and responsibility be outlined, and the workflow for referrals be outlined. and that we need to stratify such care based on the survivors and provide a model of care based on age, treatment, and risk factors. This framework or this standard really outlines what's required from a health systems, health process, and evaluation and assessment perspective. Similarly, in an Australian context, they have published optimal care pathways, which guide best practice care across the whole cancer continuum. And they talk about the continuum being from prevention and screening, early detection, right through end-of-life care. And they put the survivor at the center of that care pathway, highlighting the need to support and optimize self-management through appropriate information, education, and resources, that we integrate community, primary, and specialist services in a more formal way and do that as part of care pathways for each of the different cancer diagnoses, and also highlighting the needs of particular vulnerable or underrepresented populations and having care pathways that particularly enunciate their needs. So in terms of the School of Nursing and Midwifery, we're very fortunate to have a ECASP group where we have focused on cancer awareness and cancer survivorship. And we have a number of studies both seeking to understand and promote cancer awareness, and we also have many studies in the cancer survivorship journey where we seek to optimize quality of life. And you can see with this kind of schema here that there are many areas that we need research to optimize quality of life, and that's the focus of what we're doing within the Enhancing Cancer Awareness and Survivorship Research Group. I'm going to highlight 3 studies that I've been involved in and maybe highlight some of the policy implications of those. So the National Cancer Strategy 2017 to 2026 highlighted the requirement to conduct a national cancer survivorship needs assessment to ascertain the most suitable model of survivorship healthcare for use in an Irish context. And the NCCP tendered for that, and we in the School of Nursing and Midwifery responded to that tender and subsequently completed the work. And this is just a summary of that. And we published the report is an acute sector cancer survivorship services in an Irish context. And the authors of that report are highlighted at the top here. And this work was NCCP funded. We conducted a literature review, and that review concluded that there was a large number of models of survivorship care and many programs were evident in an international context. No definitive model predominated. We conducted a survey which crossed 25 hospitals and 184 individuals. And we found that 13% of those had a formalised cancer survivorship pathway after active treatment was complete. 13% had a formalised cancer rehabilitation programme, and 4% provided a written or electronic cancer survivorship follow-up or care plan at that time. We conducted qualitative focus groups, and it was articulated that we needed a roadmap and standardised access to a care pathway. And this was felt to be beneficial for both patient experience and lowering the burden on oncology services and staff. And we needed to recognise the nature of some cancers as being a chronic disease, and that many of the needs of individuals could be met in the community context. So that need for linking acute and primary care being very much enunciated. We concluded that the healthcare system can respond to the needs of patients diagnosed with cancer and their families in the cancer survivorship period in a much more coordinated way. In that publication, we also highlighted the ALI's model of cancer survivorship care that was generated from the data produced within the study, and that enunciated a number of principles: the need to assess individuals' key time points, the need to link individuals into the services, out from the services and onwards to other services, the need to inform and empower individuals and provide particular targeted support services. And such access to such services should be based on a stratified need and an individualized assessment. So there was need for one-to-one survivorship sessions, treatment summary and care planning, access to cancer-specific follow-up clinics, and also access to survivorship clinics. They need to be able to access a survivorship program and symptom management pathways so that individuals could access that specialist advice around certain symptoms to ensure that they are controlled or managed and hopefully resolved. In terms of follow-on work from that, we applied to the Irish Cancer Society to support the LISA trial, and that was part of a broader women's health initiative. And you can see the authors highlighted here. Professor Roisin Connolly and I were co-PIs on that application, and a large team of individuals worked together to implement a trial and a feasibility study in terms of linking women with breast and gynecological cancer to support and advice. So if we look at that study, we recruited 200 individuals, and these individuals were consented and randomized to two groups. One was an active comparative arm and one was an experimental group. Both groups completed baseline assessments around their quality of life and their symptoms, all conducted electronically, and a nutritional assessment was performed. They attended a survivorship clinic, and the active comparator arm continued with usual care, and the experimental arm had access to symptom assessments at 2, 4, 6, 8, and 10 months. And that symptom assessment allowed for triggering access to nursing and nutritional interventions and follow-up, really guided by a symptom management pathway. And that was really patient-centered. And at the end of the 12 months, they completed electronic patient-reported outcome surveys, again on quality of life and symptoms, and a nutritional assessment. We also had a parallel process evaluation conducted at the end of the study. So if we look at the characteristics of the individuals, we recruited way more breast cancer patients than cervical cancer patients. And we found that this study was feasible, and that when the individuals completed the electronic patient-reported outcomes, we could collate a lot of information about all of their symptoms. And you can see in the top right-hand corner here, the colored schema, where we have data on insomnia, pain, right through to fear of cancer recurrence. And we can see that the red and purple are areas where there are deviations or trigger points. And we can see things like pain, insomnia triggering this particular individual requiring access to support. Through the study and the analysis, we found that in the experimental arm, these individuals had better quality of life and total scores at study end relative to the comparator group, and that there were better symptom scores reflecting less fatigue, anxiety, and depression in the experimental arm versus the comparator arm. Whilst we didn't set out to test efficacy, these are promising suggestions of potential efficacy of the intervention. We also did some work in terms of the metastatic breast cancer context. And here again, this is a team effort, and individuals are not acknowledged here, and is funded by the Irish Cancer Society and Pfizer. And we looked at how we could support individuals on the metastatic breast cancer journey. Again, we conducted a systematic literature review, and we found that successful interventions were extremely heterogeneous, but they had certain common factors. They were generally more frequently administered, they involved an element of peer support, and they were multimodal. We conducted qualitative focus groups, and we found that there were unmet supportive care needs for individuals with metastatic breast cancer, and that there was a perception of lack of services contributing to the breadth of these unmet needs, and that specific groups of individuals within the metastatic breast cancer cohort had different needs. So the need for a really individualized lens when we're supporting this particular group. They made suggestions around how we could support them more optimally. They suggested integrated care pathways with more community-based services, that the metastatic breast cancer physical hub would be of great assistance, as well as a digital space with access to digestible, relevant information, and that specialist metastatic breast cancer nurses and services tailored to meet the needs would be very helpful, as well as interventions tailored to meet needs and addressing particular symptoms and issues. The real need was to shift the focus from the focus of curative intent in the primary breast cancer context to a greater shift to focus to living well with metastatic breast cancer, which is a different lens and requires that more specialist and different focus. Then in terms of the cost action work we're doing, it's I chair this network, the implementation network, Europe for Cancer Survivorship, and we seek to take a systems perspective to improving quality of life. And this is in a European Union funded action, and we have 230 members across just under 40 countries, as you can see in this schema here. And we aim to systematically support the sustained translation of evidence-based interventions into routine clinical practice as part of cross-boundary systems level cancer survivorship pathways, which ultimately enhance the health and well-being of cancer survivors. And again, this is a team effort. Poonam Jaswal is involved in working group 3, and she's also a PhD student of mine. And we have a PhD forum tracking alongside this cost action. And what we're doing is mobilizing researchers and practitioners across Europe, looking at how we can address cancer survivorship more optimally, and sharing practices, knowledge, and evidence around how we can do that, particularly in terms of using digital and electronic health solutions optimally, and how we can support implementation with an implementation science and theory lens. This is just a sample of one of the publications that is just been accepted and will be published shortly in terms of models of care and associated targeted implementation strategies for cancer survivorship support in Europe, a scoping review. And another piece of work that we've just completed is an umbrella review conducted in an oncology healthcare context where we focus on supportive care systems and models of care. And we can see umbrella reviews are being published more and more frequently. And when we look at the foci of those reviews, we can see that there are areas like lung cancer, advanced cancer, children in AYA aren't receiving as much attention. And we need more studies looking at the effectiveness of interventions supporting symptom management. If we look at the work of Cortiana in 2024, they have produced a scheme on building cancer survivorship care. They really highlight the need to look in parallel at the cancer as a disease, but also survivorship and supporting individuals with their psychological well-being and education as part of that journey. And Malika has looked at the NIH cancer survivorship portfolio and analysed areas that are maybe under-researched. And they focus specifically on underserved populations from a racial ethnic perspective, those who have rare cancers, those from sexual and gender minorities, and those that we would advance and metastatic cancer. So that's something we need to focus on in the future. And we need to look at addressing intersecting social characteristics that impact on disparity. We can look at longitudinal, longer-term follow-up, and we need to use implementation science, look at the real-world perspective on implementation of interventions. Similarly, in Australia, a realist review by Myers has found that if we're to really impact on survivorship, we need to tailor information based on survivors' background. We need to enhance communication among providers, employ dedicated survivorship staff, and dedicated survivorship training. And we need to reduce the burden on survivors to navigate their care using multiple modalities to provide information. So we need a dedicated stream and pathway and resource pathway for this. So in terms of ECASP, to conclude, within our research, we're exploring the individual's experiences of the cancer journey. We're co-designing, implementing, and evaluating e-health and digital interventions. For example, the Transcends XR Horizon-funded study that Dr. Saab has just received. And we have the LISA and the LIAMAC trials. We're exploring, evaluating the evidence pertaining to models of cancer survivorship care. Poonam Jaswal is working on that. And we are really looking at specific survivorship interventions, and we seek to influence cancer policy and practice in an Irish and an EU context. Thank you. And I'm going to stop sharing now and hopefully hand over to my colleague, Professor Gerry Lee, who will now be presenting on the cardiovascular perspective.
Thank you, Josephine. I'll just share my screen. You can see that.
Not just yet. It just takes a moment, perhaps.
Yeah, it just does, doesn't it?
It does. It's coming. I think it's coming. It's there, but we can't see the shape. We're seeing this. It's not this is it. This is
yeah,
it. Have
perfect.
it now.
Thank you. Yes, so thank you for that. As Josephine says, I'm working also in the School of Nursing as a professor of nursing. And my background is slightly different. I come from a cardiac background, but as we know, most people these days, they can either get cancer or heart disease, or if they're unfortunate, they may have both. So this work with the cardio-oncology is now established across Europe, and there are now whole hospitals of cardio-oncology, especially in Italy and Spain. And I'm a member of the European Society of Cardio-Oncology group, and also part of the ICOS, where developing education material for nurses. I need disclosures on a co-investigator on a Horizon grant. So as I mentioned, with increase in cancer treatment, we also see an increase in heart disease. And I think what's really key is that it's short-term and long-term complications that we're looking at. So there are mortality, which obviously is the endpoint that we look at, but also the morbidity. And with these toxicities, ideally, the earlier we can detect them and ideally prevent them, then we can reduce and improve the survivorship for patients following or during their cancer treatment. So a lot of work's been done about trying to determine what are the main types of cardiac events that can occur in these group of patients. And so they're classified into these 5 categories. So cardiac dysfunction, which is usually presents as heart failure or cardiomyopathy. Then an inflammatory process where there's myocarditis. You can have vascular toxicity, hypertension, and arrhythmias, and some medication we know can cause long QT syndrome. So all of this is really important that we monitor. And the European Society of Cardiology has produced quite a few documents, and the first guidelines for cardio-oncology were produced in 2022. And so that's to try and guide how we manage these patients, because before that there wasn't much evidence. So in some of these conditions and with medications, the evidence is still very low level, but there is a need now for registries in particular to monitor the cardiovascular toxicities, short-term and long-term, and for different types of cancers and in different types of patients. So we know that the key really is that do we have the patient's baseline cardiovascular risk? Is it known? And what do we need to do? So we need to do the same level of cardiovascular assessment for every patient prior to commencing treatment, or at least to have that overview. And again, it's very much about an MDT approach. And so we know that some cancer treatments will have a lower cardiovascular toxicity risk, and others will have higher. And some will require close monitoring during treatment and also after. But in terms of resources, it wouldn't make sense to be doing echocardiograms and BNP tests, troponin, etc., on these patients all the time. So it's about measuring and monitoring closely and knowing which drug causes which level of side effects. So as part of the work with the European Society of Cardiology, we've undertaken 2 consensus documents looking at what are the diseases that are associated with the various medications. And as you can imagine, the list of medications changes all the time. But just an example there from the supplemental table of what type of ones are associated with cardiovascular toxicity. And with clinicians, the more information we gather, the better. But again, it's not also looking at what medication, but also in terms of patients, is should the MDT approach, should we stop treatment because of the cardiotoxicity, or just pause it? So in terms of what should be done from a baseline, and also potentially then during treatment and follow-up, it can be divided up into these sections. And one of the key things is, has the person had a previous cardiovascular event? And that includes the risk factors as well. So have they had a history of hypertension or hyperlipidemia, or acute coronary syndrome? Then recording their age, gender and genetics. Also, if they've had any what we call medical cardiovascular risk factors, then their previous cardiotoxic therapies, it's maybe their first time they've been treated for cancer. Then in terms of the cardiovascular tests that we do, so have they had a 12-lead ECG, an echocardiogram, and any of the biomarkers? And are these levels all normal to start with? So that's important because some patients will be asymptomatic. And we know that when patients start cancer treatment, they don't tend to think of cardiovascular disease. So it's about actually making sure that from a medical and nursing and MDT approach, that we make them aware that there is an interrelationship between oncology and cardiology. And also we know that the common lifestyle risk factors, they're modifiable across both conditions. And so any improvement in those is going to improve outcomes from both the cardiovascular perspective and the oncology perspective. So what are we looking at when we talk about cardiovascular toxicity? Well, one of the key things we're looking at is cardiac dysfunction. And what that means is that the heart is to be examined from a cellular level right up to its functionality, that the cardiac structure and function is affected. And as I said, that some of these patients are asymptomatic. So that's why it's really important that we do an echocardiogram. And some of them will have symptomatic heart failure. And the other problem there is that some of the symptoms the patients may experience with symptomatic heart failure could actually be put down to their cancer treatment. So again, it's about educating the patient and their family, as well as the healthcare professionals in the community and hospital, to recognise, is this a symptom of their cancer treatment, or is this actually newly diagnosed potentially cardiac dysfunction? And so there's certain drugs we know that cause a higher risk of cardiotoxicity. So the HER2 targeted agents, for example, certain small molecule kinase inhibitors, and also some proteasome inhibitors. So the awareness of the whole team of these risk factors, and also then extending that information to the patient so that it is a shared decision making when their treatment is starting. And then obviously because of cost, we have to be aware of what test to do, when to measure. So we know that the B-type natriuretic peptide, BNP, and pro-BNP are really useful to detect heart failure. And there are cutoff values that we use for these. So they have been determined from research. And so we have a cutoff level to exclude heart failure in the acute setting. We also then have to consider subacute setting. So with some patients, again, who are asymptomatic, it may be useful just to do a BNP or pro-BNP to see if their levels are normal or not. And then what's become into sort of contention more recently is when we look at cardiac imaging, it was sort of known or accepted that we should use a transthoracic echocardiogram. But some of the research now has said it's not actually as good at predicting outcomes in terms of the chamber sizes and the filling pressures, and that actually we should be using the global longitudinal strain. So from an MDT approach, getting a cardiologist on board to review the patients, and also with the echo text to ensure that the GLS is done is really important. And it's there's been a really good systematic review and meta-analysis done recently. The link is there. So what about those with a moderate asymptomatic cardiotoxicity disease? Well, these again are patients who may sort of have symptoms, but that's mostly vague. They could be fatigued, might have slight shortness of breath, but they put that down to the fact they're not exercising as much in their cancer treatment. And the ejection fraction, usually 50 or above, we'd say is normal. And in these patients, it's dropped to between 40 to 49%. So there is a change in the ejection fraction. And so we would look at that. But if we have a baseline and then they become more symptomatic, we can then do a comparison. And that's why it's really key that we have that information, and then we can determine, is this a cardiotoxicity? And again, then the more recent research shows that even if there is a small change in the ejection fraction, but the fall in the GLS is more significant, that we should be taking that into consideration along with the cardiac biomarkers. And so like anything, if you have a baseline, it gives you that ability to see just exactly what the percentage of change is, and then is that reduction significant clinically as well as statistically. So what do we need to do? So we do need a comprehensive clinical assessment for patients. And that needs to include the respiratory system as well, because we know that some of these patients may have shortness of breath. It may be due to concomitant disease such as COPD or asthma. And we also need to know what the resting heart rate is, blood pressure, and their SATs levels. And again, the history usually is very concentrated on their oncology perspective, but we know now this checking for a history of cardiovascular disease, and given the levels of modifiable risk factors in the population, it's highly likely that majority, or quite a lot of these patients anyway, especially those who are 50 and older, will have hypertension and hypercholesteremia that may be undiagnosed. And we also recommend that they're checked for diabetes as well as obesity. So the BMI is important. And even though it's not the most perfect measure, it's what we do. Again, it has the modifiable risk factors been assessed for each patient, and that's education as well. So for patients to appreciate that, yes, they may feeling unwell, yes, they have got a new diagnosis, but we still ideally would want to modify their risk factors to reduce the risk of further events. And we know from studies that if we improve the risk factor assessment, it improves mortality and morbidity for both cancer and for cardiovascular disease. And to do then the diagnostic testing, if they haven't had it for a while, of the lipid profile, along with their 12-lead ECG, echocardiogram, and the biomarkers. So not all patients will be deemed high risk. So again, it's about resources and how do we work out who should be targeted for this. So a lot of it will be based on the medication, the cancer treatments that they're going to be having. And the Heart Failure Association, along with the ICOS, have developed what we call an cardio-oncology cardiovascular risk assessment tool, which is very useful. And so it has identified through the research that the high-risk drugs, and this is just an example of one here, you can click on the link and go to it. So for those, for example, having anthracycline, those at very high risk have a very high risk of presenting with a heart failure or cardiomyopathy. And it does a score then, depending on what their risk factor profile looks like. So there's the patient then will be given a classification if they're very high risk, medium, and then as you can see, there's medium risk factors which get 2 points each. So if the age, obviously that's not modifiable, but having the ejection fraction is really important. And then there's medium risk factors. So again, that having a comprehensive cardiovascular assessment prior to treatment will potentially highlight any of these issues. Because what we don't want is the patient to develop complications and then say, well, actually, what was their risk factor profile? And all of these are important things that we potentially can address. So for those, the key is that the patient then has got a risk factor profile, that should be documented in their notes, but also that the patient is aware of this, so that if they develop any symptoms, they know not to ignore them, and that they could be related to their cancer treatment. And there's a clear, from the ESC, clear pathways. So once the patient has been categorized according to their baseline cardiovascular risk assessment, they can be the low risk, moderate, or high to very high. And based on the evidence, as you can see there, from class 1 to class 2A and class 2B, we try and have what should be the surveillance and monitoring during cancer treatment, in the first year following their cancer treatment, and then the long-term follow-up. And for example, you can see there for patients at low risk, they would, in terms of the long-term follow-up, they just need an annual risk factor assessment. But also, and even though there's very little evidence for it at the moment, is reassessment for new cardiovascular signs and symptoms. Whereas the person is high or very high risk, we would expect them to have referral to cardiology and to start actually some CVD prevention. Now that may include starting antihypertensive medication and statins. And then in terms of the long-term follow-ups, you can see with the recommendation currently with class 2A evidence is that they should have an echo every 1, 3, 5, and then every 5 years, and an annual assessment. But the key is as well is communicating to the patient that if there's any new symptoms, that they need to actually alert their physician and have a named person from either the oncology team or cardiology. So the guidelines at the moment are there, and the interesting thing is when you look at the quality indicators for these, as you can see, the levels of evidence are still pretty low for some of them. So it's well established what we do in terms of the actual cancer treatments itself, but from the cardiovascular toxicity, the evidence is still being gathered. And as part of the work that we did in the ESC was looking at what are the key domains for care for the prevention and management of these toxicity in cancer treatment. And to do that, we did a systematic review of the literature, looking at the QIs, and then selecting a final set. And as Josephine was talking about with survivorship, there's a lot of information about quality of life. And interestingly enough, with the QIs, the literature in terms of cardiac toxicity just isn't there at the moment. So we followed a process looking at structure, process, and outcomes. And that paper then was published in 2023. And there were 5 main quality indicators. And I think this highlights, as I mentioned, we talk about resources. So that's structural framework. So is there, and as I mentioned, across in European countries, they have the cardio-oncology hospitals. So that structural framework to support assessment. Then the baseline cardiovascular risk assessment was seen as critical, as you can probably imagine from the previous slides. Then looking at what are the cancer therapy-related cardiovascular toxicity that occurs, what are these predictors of outcomes, and then what's the monitoring complications during therapy. And one of the key things is you can have, when you're looking at structural frameworks, every area is going to be, in every country is going to have different resources. So the basic cardio-oncology patient care should involve the cardiologist, the oncologist, and the specialist nurse. And of course, if you had to have an MDT approach, it's going to include a lot more people than that. So I'm not going to go through these in details, but just to show you that there, in terms of the cancer treatment, it is really about, as I've just mentioned, their previous history, looking at the patients, proportion of patients considered for cancer treatment who have these modifiable risk factors identified, and then also the proportion of patients considered for cancer treatment who've been engaged in the shared decision making when deciding treatment strategy. So if you were to look benchmark care, all of these quality indicators should be seen and be evidenced and documented in each patient. Again, looking at the toxicity, I'm very clear about, do we know the annual rate of hospitalization due to it? What's the proportion of patients with symptoms, either during or after their treatment, who have a cardiovascular assessment? And then the proportion of patients at high risk who are followed up, and what's the adverse event rate. And probably at the moment, we don't have a registry in Ireland, so we just do not have this information. So it's really key, if you're going to have quality indicators, that you need to collect as much data as possible. And the predictors of outcome, again, looking at those who end up having ejection fractions that are reduced and have heart failure, for example. And also we know with the medication that the earlier, especially with guideline medication management in heart failure, especially with the SGLT2 inhibitors, they've shown a huge reduction in mortality. So the earlier we know we start this medication and optimize it, the better. And again, looking then at compliance. So when we're monitoring during the treatment, is this being done? So one of the things we did look at was HER2 targeted therapies in particular, especially in the first year of treatment. And is that assessment and being taken seriously and being done regularly? So in the States, in particular in Europe, there are now the cardio-oncology services. So that it's talking about who is part of the team. And as I mentioned, we can have a very basic team, but if you are going to have a dedicated services, these are all the people that have been identified that would be part of your team. And can this service run and is it resourced properly? And a paper from 2023 actually looked at this, where they had cardio-oncologist, the nurse who's an advanced heart failure specialist, the cardio-oncology pharmacist, the coordinator, the nurse practitioner, and various other people, and radiology, etc. in there. And what they found was that basically this, if you had this and had the proper infrastructure, that there was accountability, there was standardized care, you had the dedicated resources, the patients then had a good experience in education, and also there was a branding, so patients knew where to go to, so they were able to navigate the healthcare services. And interestingly enough, build it and they will come, as they say. So what it showed that over time, they had greatly increased improvement in the workflow when they applied the quality measures. But also, as you can imagine, the workflow needs resources as well to be able to run it. Other thing that we know from the guidelines is that patients, they can't read our scientific documents. That's one of the key things we did as part of the cardio-oncology group, was to actually do patient lay summary guidelines. And that was really a simple booklet that patients could have to know what to do, who to contact, and what their tests were, etc. And it wasn't just about the language, it's also about using pictures so that the patient would really feel that they were part of that decision making. So overall, we know that basically you should have a structural framework in place for to optimize your cardio-oncology service, and that there should be processes in place to assess the risk prior to, during, and after treatment. And one of the key things is the shared decision making, so the patient and their family feel part of this, and having patient-friendly advice, and that the patients are clearly informed about who to contact, and that they have the correct contact details. And based on that, I'm planning on putting in for a HRB investigator-led clinical trials call. And the idea would be to look at individualized comprehensive cardiovascular management for women at high risk of cardiac toxicity from breast cancer, looking at doing a feasibility study. So if anybody is interested, would be really good to sort of bring oncology and cardiology together. So do send me an email. And there's some key documents there. The first cardiology conference that the ESC is running will be in Florence in June, so just a bit of a plug for that. But I think it's a growing area, and there's certainly no doubt that it's needed. And the more that we can get an MDT approach, the better the outcomes for all our patients. Thank you.
Thanks so much, Roisin here. I am going to help navigate the questions. I think Mags Allen, who was hoping to moderate the questions, has had some technical difficulties. So thank you, Mags, for being present on the call and for trying your best to connect. And I think there was a number of issues today with the links, so apologies. And we will try to figure this out for future. So I'd like to say thank you very much to Professor Hegarty and Professor Lee for giving us these lovely presentations today. If anyone has any questions, please pop them into the chat and we can have, or put up your hand and we can have you speak. I think these two areas are so important for us as we move forward regionally, and the idea that we have experts in these areas sitting next door to us in the School of Nursing is a big bonus for us here in the South. So I'll just take a look and see, are there any queries coming through? If not, I will start to ask some questions and get the conversation started. I know that we have people on the call here as far away as Waterford. Some of our colleagues in Waterford with expertise in geriatric oncology as well, I think, have been on the call. So I think this area of supportive care for our patients is so important. And Gerry, I might just start with yourself. Towards the end of the presentation there, you were discussing the idea of having booklets and things for patients so that they can be, educated about this whole area. And I think we're discussing similar things in the area of survivorship, and we should be discussing it in the area of geriatric oncology. There's so much supportive care that we should be, supportive care and education that we should be providing to patients, that we've been having discussions over time about the idea of having, a centralized location like an app or a platform where patients can access information, almost from and then have some self-management advice, where patients might be able to go in and take some simple advice, and only if that's not working, and that they might be able to then reach back to the clinical teams at site. Have you seen anything in that area in cardio-oncology? And then maybe Josephine can speak about her experience as well, because this would be amazing if we had this available to our patients regionally, this type of approach.
Yeah, so there's 2 points. So one, in the States, they have what they call navigators, nurse navigators, who really sort of assist the patients when they are trying to navigate the healthcare system. Because I think for us, we know what to do, but when you're, if you do get a symptom, who do you contact? Do you go to the, you see the news about the emergency department, so you think, I better not go there, but then your GP doesn't have the knowledge. So I think we had navigators as part of the resources would be really good. With this booklet on cardio-oncology, the idea was it was actually written by some of the doctors. And then I looked at it, I went, guys, you're using terms like you will die. I was going, this is not very patient friendly. So it was rewritten, and the idea is to translate it into various languages. There was a research done in Belgium where they did an app for actual atrial fibrillation and looking at educating patients and where to go to. And they found that patients' knowledge improved vastly, but they didn't implement the changes to their own lives. So they knew what to say, but they didn't actually apply it. So, but I think resourcing as well. A lot of the research shows that now it's like that branding. If we had something, either with HSE, / UCC, it would be a trusted brand, and it probably would be quite successful for patients. And the interesting thing with the work on digital literacy is actually older people have got quite good digital literacy. A lot of their families, everybody's international these days, so they're able to use FaceTime and various apps. So we shouldn't. One of the things I've learned from doing my research, 80-year-olds, they were like, why do you keep excluding us? Why do you think we're not digitally active? We are. But I think an app would be really good, and then we could put potentially red flags, where then saying if you're getting this symptom, act immediately. So it would reduce the impact on resources, but also give patients that assurance if they want to just check something very quickly, they could do that.
That's great, and I'll let Josephine comment, but just I suppose just to mention the navigator piece that has been raised as something that's critical. We're moving through the the European accreditation process at the moment for OECI, currently for CUH as a cancer centre, but imminently moving forward from a network perspective to cover all of our regional hospitals. We actually have navigation to some degree with our clinical nurse specialists, but it's connecting the dot between those. For example, in the case of breast cancer, we have breast surgery clinical nurse specialists, and then the patient is handed over to the medical oncology clinical nurse specialist. And then it's like, if you have this problem, talk to this nurse specialist. And if you have this problem, come back to this nurse specialist. So I think what we need to probably do in our system is figure out what current resources we have, who's currently providing navigation, and is there a way to optimize that, across the service?
I think that's why in the States they did that, because everybody's going to the individual CNS, and it was just making more work. They was going to the nurse practitioner, but they're saying, well, actually, you should start with the navigator, and then the navigator can basically just work out, who do they need to contact? So because the workload.
Right.
I come in, so Roisin, and thank you for that, Gerry. In terms of the question around information and how we can ensure that individuals have access to information, I suppose it's great to do it at an individual service level, but I think we need to take a national perspective on this. A lot of the information is quite uniform in terms of information around side effects or different risks. I've just printed a link to the Australian example in terms of their work that they've done in terms of optimal care pathways, and they have resources for physicians, resources for patients, and they have looked at different groups and the needs for maybe resources that are more tailored to their needs, because was all of the various resources should be NALA certified in terms of English language level, there are needs that are unique to different populations, and we need to maybe recognise that they may need the information in a different format. So I think we can do a lot as individual services, but I think it's incumbent on us to have a national leadership on this through the NCCP and the various key stakeholders. And a lot of this work is happening, but having models of care or pathways that are really highlight what ought to be standard of care for everybody, not just in a research context, looking at standardized information that you can pull off in either digital or paper format, because people, once we recognize that a large portion of the population are digitally literate, there are individuals who are maybe not as literate and would need maybe the paper version. And we also need to look at, as I mentioned earlier, there are gaps in our underserved populations. And I think you mentioned there were colleagues from Waterford here, and the older adult cancer survivor population are really important because of their multiple comorbidities. So they have additional difficulties that we need to maybe consider as part of this conversation. So we've done tremendously well in terms of, and are doing really well in terms of primary treatment. So we just need to catch up maybe in other areas where we look at that, having the kind of a service that we had as part of the LISA trial available more broadly to all cancer groups, and have it resourced appropriately, because there are rarer cancers that perhaps don't have as much resources, and their symptom management pathways aren't as well defined, and there are rare symptoms that don't have the resources. And we are very much in an Irish context dependent on that idea that I know somebody, I can refer somebody. So I think we need to move away from that, because then the person goes and that service falls down. So we need to have very clear pathways for us to allow for referral, be it through navigators or whatever system is thought to be appropriate. But that is very clear that this is the standard of care we expect for everybody. And that minimum standard of care that they're outlining now in a US context in terms of cancer survivorship, and in the Australian context, they've said, if we want to be here in 2 years, we want to be here in 5 years, we want to be there in 10 years. So they've strategized to do it over a period of time. So it's not going to happen overnight, but we need to call it out. We need to understand what it is, be it from a cardiotoxicity perspective or from a lymphedema perspective if you have breast cancer, whatever it is. It's just meaning that we have clear pathways for supporting individuals and accessing that support in a timely manner.
Thanks, Josephine. I know we're almost at the hour. There was a question around the use of dexrazoxane. And I think Gerry has provided a response to that. So definitely an area of interest. So I just wanted to thank everyone for being here today. I wish we had more time to chat, but I think they were two fantastic update presentations. And just to let people know that our next seminar series is March 10th. And we'll have a focus on hemato-oncology. So Dr. Rory Crotty from Pathology and CUH will give an overview of the role of the pathologist in the care of these patients, and a new consultant, Rachel Brodie, on aspects of genetics in myelodysplastic syndrome. So hopefully you can join us at that meeting. And thanks very much everyone for their time. Any final comments or thoughts? No, everyone clear. Great. Thank you very much, Gerry and Josephine, for your time. Thanks so much.
Thanks.
Bye-bye.
Bye.